So let's go. Thank you again for joining. We have great speakers today, and all my old friends and mentors. And I will start with Dr. Luke Kaplan. He's a professor of neurology at Harvard Medical School and Beth Israel Deaconess Medical Center. He will speak on neurology and coronavirus COVID. Dr. Kaplan is a living legend in neurology. And thank you, Dr. Kaplan.
Thank you, Steve. Yeah, it's a pleasure. I have a lot of Indian friends, and it was an honor to be asked. Although when I was asked, I told Steve, you know, I've been on house arrest by my children and also the department chairman, so I haven't been in. So I actually have not seen very many of I haven't seen anybody with COVID. And by coincidence, this morning, I'm doing a book on the history of stroke. I was reading a treatise on apoplexy by John Cook that was written in 1820. Cook had worked 20 years in the London hospital, and then he wrote a very long treatise and analysis. And on the last page, he said, you know, it's funny. I was at the London hospital 20 years. I never saw a patient with apoplexy, but all these other guys did. So I thought I'd tell you what they said. So I'm going to try my best. I'm going to try to share the screen. Oh, how do I, wait a second here, share screen. I have to get,
I think first downsize the screen.
I don't know if it's on.
Downsize the screen and open the PowerPoint, then open the screen and then share.
Okay, so to put it down further.
Further down, then open this PowerPoint.
Yeah, wait a minute. Okay, it's open. Can you see it?
Now you have to open the Zoom and then share screen.
Okay, so did I do the share screen first?
Yeah, click now. Yeah.
And now, is it showing up?
Not yet.
Not yet.
Yeah. There we go.
Wonderful.
Okay. So what I did was I asked one of my colleagues, Vasilius Leotis. He had just presented to the Boston Stroke Society. And in doing that, he talked to the people at the other major Boston hospitals and let me know a little bit about what was going on. And the first thing, I don't seem to be able to move it. Maybe this way? Yeah. The first thing is a dramatic decrease in the number of stroke patients to the hospital. And this is a weekly chart of that. This is on the left is for all strokes, on the right just ischemic strokes. And this was true in the other hospitals in Boston and actually over the country. And then he asked Australia and some parts of Europe. Now, the wonder was it that people just weren't coming in and the minor strokes were staying at home? So there were not only fewer stroke patients, but a lot of the places do telestroke, and there were fewer telestroke consults. There were fewer severe strokes, but there were also fewer minor strokes and fewer TIAs. When the patients came in, they didn't seem to have any important delays in their presentation. That is, the time from when they got symptoms to when they came in seemed to be the same as before. And there wasn't any difference in the way they were handled in the hospital, how quickly they were seen and how quickly they were evaluated. The problem was they were cared for, and I don't know how this was in other parts of the country and actually in India. So when they came in, they had to be cleared for COVID. They were often on a different ward. And if they weren't acute and didn't need acute TPA or acute removal of thrombi, then there was a day or two and they were taken care of by the consult service. So probably the quality of care was not as good as it might be. But the interesting thing was there were very few COVID patients that actually presented with stroke. They'd seen them in other places, but we didn't see them. Now, one of the striking things, and this was very dramatic, there was a grand rounds of all the Harvard hospitals and by coagulation hematologists. And one of the findings was very hard, dramatic increase in CRPs and other markers of inflammation. Now, there'd been a fairly wide literature over the years that if you had an infection, a serious infection, or if you had an inflammatory disease, Crohn's disease or ulcerative colitis, you then would have high inflammatory markers and your acute phase reactants would go up. So your factor VIII would go up, your fibrinogen would go up, and you would be much more hypercoagulable. But this was out of proportion when they looked at the ordinary flu, other usual infections. They didn't see the dramatic increase in sed rate, in CRPs, and other biomarkers, and the highest was in D-dimers. Some of the patients had D-dimers in the high thousands, even 10,000s. They also had very high fibrinogen levels. And one of the things I've always preached is getting fibrinogen levels on stroke patients. First of all, fibrinogen goes to fibrin, is a component of clots. It's also part of it's a very heavy protein, so that it actually increases whole blood viscosity. And it's also very important in plaque developments because it ends to plaques. So the fibrinogen levels were really quite high. They also had elevated factor VIII and von Willebrand antigen activities. But the striking thing was, unlike a lot of the other coagulopathies, they didn't have DIC. The platelets didn't go down. So this was a fairly unique coagulation signature. Now, the other thing is they also had an increase in fibrinolytic activity. So as we'll see, some people started to have systemic hemorrhages. There were occasional brain hemorrhages. And this gave them pause because although they wanted to protect the people from pulmonary embolism and coagulation, they were worried that if they gave too much anticoagulants, it might precipitate a hemorrhage. So it was a major concern. And this is a graph that shows, I think, from China, the dramatic. So the blue are the survivors, the red are those people who died, and these are the fibrinogen, the D-dimer levels. So the higher the D-dimer level, the less chance you had of surviving. So they were making clots and fibrin basically all the time. Now, if you look at the clinical thromboembolic findings, this is from the Netherlands. Among 184 consecutive patients in intensive care units, 13% died. 31%, a third, had thromboembolic events, but they were mostly venous thrombosis and pulmonary embolism. So one reason I think why the ventilator doesn't fix everything is because the blood flow is diminished and many of the patients have pulmonary emboli. Only 3.7% had arterial strokes. In New York City, they had 5 cases of large vessel occlusions in very young people, and those cases presented with strokes. That hasn't been the case in Boston. I don't know if it's been the case in other cities, but we've not seen that. There have been some systemic and brain hemorrhages, not very many. And it looks like from pathology when it's been done, there's an endotheliopathy that occurs, plus a coagulopathy, and increased fibrin generation and increased fibrinolysis. So what do you see? The difficulty, I think, in a lot of these cases is they're sick. It's not easy to get brain imaging. It's hard to get MRI. It's hard to transport them. A lot of them are sedated if they're on a ventilator, so they're not examined that carefully. But a good many of them have what's been called an encephalopathy. They have no focal signs. They're sometimes delirious. Sometimes they have decreased activity. And if you do an image, you sometimes don't find anything. Surprisingly, when they've had spinal fluid, it's usually negative. Some people thought this was an infectious process or a meningitis, but the spinal fluids have usually been negative. Many of the patients, because they go into shock, they have respiratory failure, they have pulmonary emboli, so they're often hypotensive. And one of the things you see fairly prominently in the people who've on a respirator and are hypotensive is you see white matter damage on MRIs, particularly around the ventricles. And this may be also because some of them may have an enzymatic defect. That's been found in people after cardiac arrest, belatedly. They often have very extensive white matter changes on MRI that are diffuse. Some of the patients, of course, have a myocardopathy. So it's very common for them to have cardiac enlargement, some pericardial fluid, and some of the patients do have cardiogenic embolism to visceral organs and also to the brain. Some people have small, scattered, relatively small infarcts that are presumed to be due to the coagulopathy, and they're particularly common in people with high D-dimers. There are occasional patients who look like they have an ATOM-like picture, mostly white matter and scattered, that looks like it's an immunological type of reaction perhaps to the virus. You rarely see large artery territory infarcts. Occasionally, the patients have had brain hemorrhages, especially if they have systemic hemorrhage. There have been a couple cases with dural sinus occlusion, and in those with headache and decreased enrollment, you always have to think of dural sinus occlusion as part of it. And occasionally, there have been patients that are reported who have a Guillain-Barré syndrome. They start to develop peripheral weakness, and of course, if they've been on the respirator for a period of time, they can develop a chronic neuromyopathy from chronic disease as part of their picture. And that's basically what I've been told about it. I go forward to hearing from people who know a lot more about it and who've actually seen patients. Thank you.
Thank you, Dr. Kaplan. That's a very amazing talk. Thank you so much. We are honored to have you here. And next is another living legend in endovascular neuro interventional surgery, Dr. Professor A.J. Waklu. He's from Leahy Hospitals and Medical Center, Professor of Radiology at Tufts University School of Medicine. Dr. Waklu.
Yes, first of all, thank you very much, Steve, for putting this together. This is the first time I've been in the society invited, and thanks also to be among, you know, great speakers and legends, as you mentioned, Lou, Suresh, of course, Ajit, and Anil. I hope you guys are not tired of the Zoom. I know there have been a lot of meetings on the Zoom. So from our side, from endovascular thrombectomy for acute stroke associated with large vessel occlusion, there have been few challenges, and I want to walk you through them. One thing is, like you heard from Lou, that there are patients coming later, presenting later in time after the onset. We call them wake-up stroke. And it seems to be more common now during the COVID-19 global pandemic, worldwide actually. The other thing is, we know on the other side that endovascular treatment is highly effective and safe, as shown in multiple studies. And then what is critical, and I think more so in the COVID-19 time period, and I want to show you a little bit why, is that we strictly adhere to imaging findings. We select our patients carefully to get that beneficial effect. And then, which is getting more and more traction, is that, and in the COVID, we are seeing that probably more than we had believed, that patient may benefit from endovascular mechanical thrombectomy beyond 24 hours. And I think there are people trying to put together several trials in the United States and outside the United States to basically prove that. Now, this is one of these critical findings during the last 3 months, put together here by Clemens, who used to be in Boston and is now at Geisinger. And what they have found out that in this period of COVID-19, there have been a significant increase in the late admission to the ED. You see the difference was on average by 160 minutes between the onset when the patient was last seen normal with admission and treatment. and the data speaks for itself. And I wanted to compare these findings with our own data. Here, a patient who comes, who is 92-year-old female. She has some underlying disease, and she has an NI stroke scale of 19, and she was seen last normal at 9 p.m. So one of those, what we call wake-up strokes. I will go quickly through some images. It's typical. We do our CT scan to rule out bleeding, and you may nicely see now a cutoff of the left middle cerebral artery, and she's transferred with these findings that were ascertained outside to our system. And here's the triage. So when patients with an acute ischemic stroke present to the ED with large vessel occlusion, we have to decide, is that a patient to be considered for angiography and thrombectomy or not? That decision has to be made very quickly, as you see, for those who are not in the neuro domain, here put together by Jeff Saver in stroke a while ago. What we lose every time we waste basically or delay the treatment. Now, this is not written hard in a stone, because there are a lot of other factors that may play a role, like collateral circulation. And that brings me to the next slide, which is very critical, and more so in the COVID-19 era. We are seeing 3 groups of patients that present to us strokes. One, which within few hours have this malignant form of a evolution of the stroke, where even if you revascularize the occluded side, they don't benefit from it. And then on the other extreme, we talk about the slow growing population, where you can wait, like I mentioned, maybe more than 24 hours, and they may benefit from the treatment. And in the COVID era, we are seeing that more and more. And that has been nicely captured in 2 recent trials, the DAWN trial and the DIFFUSE-3 trial. One used CT, the other used MRI. And it was interesting that in that subgroup population, where treatment was offered to the patient up to 24 hours in DAWN, and between 6 and 16 hours, had a significant good clinical outcome. As you see in the DAWN, 45% versus 17% in the control arm, and in the DIFFUSE, 49% versus 13%. And Greg Albers, for those who are interested, wrote a very nice paper in Stroke recently about that. And now with the COVID, and this is put together by the group from Tudor Jovin, that they are probably more slow progressor with acute occlusion. Here you can see the stroke volume, and then patients who are in the later field. We are talking about more than 50% of the patients, and that's the group we want to capture in future. And they have fairly good outcome here, put together by Tudor Jovin's group in the Aurora thrombectomy outcome study. Here put together all the data, and I will go a little bit quicker through that. And these patients definitely benefit. So that's the question which we have to answer now in this period. Can we design a trial in the subpopulation showing that even revascularization in patients beyond 24 hours may be of benefit? So in our patient that I was presenting to you, we then moved forward to the what we call CT perfusion study, showing you on the left hemisphere the large salvageable area. We don't rely all the time on CT perfusion because there has some limitations, and I'm sure that Suresh will address that. This is our patient, the 92-year lady with a left MCO occlusion. Standard approach, we use what we call a aspiration combined with stent retriever, and that's how the clot was removed. Single pass, we prefer to open up the vessel with a single pass, and the results in this patient, the result was terrific. We could salvage a lot of brain, and she was discharged home with to the rehab with an ISO 4, and there are no residual deficits at 2 months. So this is a good outcome. Of course, it doesn't work always like that. So at our place, we have developed a timeline which is used internally for our monthly meetings. And I think it's very beneficial to stick to that, because there can be fine tuning at all these different time steps needed to improve further your outcome, more so again in the COVID era. Now, when we work on these patients, we have to do parallel processing. And I think it's very critical to understand that stroke treatment is not a one or the other part of the physicians or groups that do that. It's really a unique opportunity to work together with all the various groups. Now, since Suresh asked me to put together something for the COVID, I want to share with you the data over the last few months from Leahy Clinic. So these are all total numbers of TIA and ischemic stroke that were admitted in 2019 in green, 2020 in white, and the COVID patients at Leahy are plotted in orange. So all patients that were either in the ICU or on special units admitted. And as you see, we had a trend of increase in stroke patients overall and ischemia, and then suddenly TIAs, and suddenly you see a drop in March, April, and May as we got an increase in the COVID patients. So there were less patients with ischemic stroke or TIA admitted to the hospital. Interesting finding. Now, on the other hand, however, for the mechanical thrombectomies, if we compare our data from 19, which were small because we had just received in May of 2018, the Comprehensive Stroke Center certification, we saw an increase in stroke during the month of March, April, and May. So while the number of total TI and stroke went down, the number of mechanical thrombectomies went up. Same thing with IV thrombolysis. Other centers have seen a decrease. In our place, we saw an increase during the same period as compared to 2019. What it tells us is that patients with smaller strokes or TIA stayed or preferred to stay at home, while patients who were fairly sick or had higher NI stroke scale were admitted for advanced treatment. This is something which BI and Leahy shares. It was developed over the past few weeks. Various groups have they sat together to come up with a flow chart for patients who either are asymptomatic with or without COVID positive, and how do we deal with them if they present to the ED with stroke and other procedures as well. So this applies to procedures as well as to OR patients. And the interesting thing is we are moving now completely in patients where we don't know the past clinical history to general anesthesia or stroke treatment. And that is a significant paradigm shift as to before, where we preferred to use MAC anesthesia. This is from the World Stroke Organization presentation by Dr. Wu. I took it from him. He presented it just the other day. They have come up also with a very intelligent flow chart, how to address these patients. And as you all know, we will have to deal with that probably in the coming months and maybe until next year, until vaccine is around. So it is very intelligent to come up with a flow chart and adhere to that. However, unlike our place here in China Hospital from January to May, while the COVID was being transmitted and people were falling sick, they saw a decrease of total admissions during the same period as compared to 2019. And these are the hard numbers. So you see the total admission as compared to last year down by 1/3. Same thing with IV alteplase, because the patient just showed up later, dropped by 50%. There was some increase in endovascular, as you see, like our place, doubling of endovascular treatment. So that goes back to my initial comment that we have now an opportunity to utilize the mechanical thrombectomy and discern those patients which may benefit beyond the time frame. These are the challenges. Some of them we do have here in our country as well, and that is less availability of CT scanners during the period of time due to the cleaning and patients who were COVID positive. So some of the scanners had to be kept unused for a certain period of time after deep cleaning. With that said, thank you very much. I'm more than happy to answer some questions.
I think we'll get to questions at the end, correct?
So, yeah, we take the questions at the end. And thank you so much, Dr. Waklu, for the amazing talk. And next, I would like to invite Dr. Suresh Mukherjee, my old-time friend and a shining star of radiology. Suresh, please take over. Thank you.
Great. Okay. Thank you very much. Can just give me a thumbs up. Can everybody hear me okay?
Yes.
Great. Okay, let me just get this. First of all, it's a pleasure to be here, and thank you for having me. I tend to use my little pointer here, so hopefully people can see that. And let me, great. So what I was asked to do was just anywhere between 8 and 10 minutes, and it probably won't even take that long, is to talk about specifically the neuroimaging findings in COVID. And I do want to acknowledge some people that have provided me slides and content for this. And this includes Dr. Mohan Siyash Mohan, one of my old fellows from Penn. Rajan Jain is, again, one of my old fellows that's now currently at NYU. Prashant Raghavan and Chris Mosier. And I guess it's a little frightening for me because I trained in the last century. I hate to say that, at the Brigham. So I guess I'm making the transition to elder statesmen, but it's nice to see so many of my trainees doing well. Take what I'm about to say in the context that it's meant and nothing more. And that is, over the last 30 years I've been doing this, I think I've literally given close to 1,000 talks at some point in my career in toto. And I've never put together a talk where I've been having to make substantial content changes up until literally an hour before the talk. And that's because the amount of information that's coming in is constantly changing. And oftentimes it's inconsistent. And as this information is coming in, it's due to a lot of different factors. Part of it is based on some of the papers are being released before they really had sufficient peer review. Some are papers that are being, quote unquote, in press. As a result, and as I mentioned this in the last slide, there is this almost fog of science that we're going through. So what I've tried to do in my talk is, as of Friday, June 19th at 7:31 p.m. Eastern time, this is the current up-to-date information. And by the way, I'm getting some feedback. If someone could put their presentation on mute, I'd appreciate it. I don't know if anybody else is getting that feedback. But what I've tried to do is consolidate the neuroimaging findings into 4 buckets, if you will. And this really is based on the most up-to-date papers in the literature that's come out. And I've divided into direct involvement by the virus, into hypercoagulable states. I will talk about, as Dr. Kaplan mentioned, COVID encephalopathy and some potential causes of that, or at least the findings of that. And then also the whole concept of the associated diseases with COVID. So when we talk about the neuroimaging findings, these are the clinical findings, and they've been described as dizziness, headaches, altered consciousness, stroke, ataxia, seizures, anosmia. Specifically point out anosmia because from a back to work and a preventative measure, people are specifically asking for whether or not there is loss of smell, a loss of taste, visual changes, any type of neuropathy. Now, the neuroimaging findings vary anywhere from 8% to 44%, and that is a wide range. And the findings that have been described include infarct, lacunar stroke, hemorrhagic stroke, temporal lobe involvement, and we'll talk about causes potentially for this, the white matter lesions that were previously mentioned, hypoxic ischemia changes, and microhemorrhages. And this is based on the papers that I've listed below. So let's initially talk about direct involvement. And again, direct involvement has, if you will, has been a little bit controversial. And in fact, I'll show the most recent papers that have come out over the last week. But I would argue that this is the one case where I feel very strongly that this is real direct involvement. And this was the paper that was published in the ENT literature. And this was a 40-year-old female with acute loss of smell. And what these yellow arrows point out is a focal area of abnormal mucosal thickening involved in the superior nasal cavity. And then when we look at the T2 weighted R, we can see this abnormality here again in the superior nasal cavity. The yellow arrows point at the olfactory nerves that are located in the olfactory sulcus. And this area superiorly is the gyrus rectus. And these are the heavily T2 weighted images. And in the paper, it was suspected that this area of abnormality was the actual disease. And the reason why the patient had loss of smell was because of involvement of the olfactory nerve. Now, based on a CT or an MR, it's really hard to make a definitive diagnosis, but this was a paper that was published online again in May 29, just a few weeks ago. And this demonstrates abnormal signal involving the olfactory nerves. And then if you look at the gyrus rectus, we can see abnormal signal. So this was actually edema. And this is likely due to the neurotropic effects of COVID. And some of the coronaviruses have been shown to have direct neurotropic effects. And this was a follow-up MR that demonstrated resolution of the high signal involving the olfactory nerves. And then we looked at the gyrus rectus, and there has been resolution. So this, I would argue, is pretty definitive of direct involvement. Now, this was the first paper that was published that actually demonstrated, if you will, COVID findings in the brain. And this was felt to be due to acute necrotizing encephalopathy. And this was published by the group at Henry Ford in Detroit. And what we see is abnormality here involving the thalamus. We also see abnormality involving the temporal lobes, and we also see small areas of microhemorrhages. Now, we as neuroradiologists, when we first see this, we think that this could be thrombosis of the internal cerebral veins, but they were actually patent. So this was felt to be attributed to acute necrotizing encephalopathy. There was some thought whether this could be due to herpes. Could this be an immunologic response due to limbic encephalitis, or potentially the robust cytokine response that's been associated with COVID? But this was the first reported case, and this was felt to be due to acute necrotizing encephalopathy, and it was unclear whether it was due to direct involvement. The second area, and Ajay talked about this, was just the hypercoagulable states. I won't say too much about this. I think he's beautifully and eloquently gone over the hypercoagulable states. This was just a patient that had acute embolic infarcts. These are some of the quote-unquote hemorrhages that we have seen in COVID, and these are hemorrhagic transformation of some of the embolic strokes due to the hypervascular state. And this was a patient with the direct cutoff here and an LVO involving the right middle cerebral artery. And this, when we look at the common carotid artery, there was a large clot in the common carotid artery. The only thing I'll add of what Ajay and other speakers have mentioned is that if you do look at RAPID or any of the predictive analytic measures that are looking at perfusion, the overall usage of these has dropped too. And whether or not less patients are getting strokes, whether or not they're not coming to the hospital, or possibly they're not under the stress or they're not exercising, it's hard to say what the real cause is, but the utilization of these predictive analytics has decreased. The next thing I'll talk about is this concept of COVID encephalopathy. And this is a real confusing topic because a lot of quote unquote brain findings have been attributed to what we referred to as the COVID encephalopathy. Well, this was a patient with quote-unquote COVID encephalopathy, and we see in this particular case abnormality involving the spleen of the corpus callosum. We see abnormal signal involving the and centrum semiovale, and abnormal signal involving the precentral gyrus. Now, this is a pretty classic case of hypoxic ischemia, but quote-unquote, it falls under the rubric of COVID encephalopathy. And this paper was just published in the New England Journal, literally just as on 6/12, earlier, a week ago, literally, demonstrating that they had 18 patients that underwent brain autopsy, and there was no evidence of direct viral involvement. So the things that we are seeing in COVID encephalopathy are probably not due to direct viral invasion, but are due to other etiologies. This was a paper that was published at this was just 2 days ago, that was published in Radiology. This was in one of the microhemorrhages that's been described in COVID encephalopathy. Again, it's not due to direct brain involvement. This may be due to a small vessel vasculitis, possibly hypoxia, and importantly, these patients did not have DIC. So this was not a diffuse coagulopathy. Rather, this was just seen in these patients with COVID. And this was a patient with sort of these white matter lesions that we're not really sure what the cause of. Now, if you told me as a neuroradiologist and I see this, I think that this is probably due to ADEM, acute disseminated encephalomyelitis. But because it's in COVID, it had thought, well, maybe again, it's due to direct viral involvement. But in this paper from the Kremer, which was a multi-institutional study from France, they identified that only 1 in 37 patients that had neuroimaging findings, only one of these had positive CSF RNA. So basically, this is not due to direct viral invasion. And my suspicion in this type of COVID encephalopathy that this is due to some type of immunologic encephalitis or potentially some type of leukoencephalitis. And the last thing that I'll talk about are the associated diseases. And these are patients that already have other abnormalities that also have COVID. So this was a patient that had GIST and also had COVID positive. And in this particular case, there was a diffuse mastoiditis, and they also had an abscess. And I showed this specifically because sometimes the symptoms that patients have or the imaging findings that patients have that are COVID positive are not necessarily, again, due to COVID. You know, we see patients, we've been seeing patients with mastoiditis for years, and Frederick Bezold was a pathologist at the turn of the 19th century, so these disorders have been around for a while. And if we see this, this really is an associated disease and not specifically due to COVID. So in summary, what I've tried to do over the last 10 minutes or so is talk about the various disorders associated with COVID and the neuroimaging findings. They're likely attributed to direct involvement, and we specifically talked about the anoxia. Ajay beautifully went over the hypercoagulable states. We talked about potential causes and patterns, if you will, COVID encephalopathy, and there's enough data to show that this is not due to direct viral invasion, but likely due to immunologic responses. And we talked about the associated disease. And I'll just leave you with this last quote. I think we all understand the whole concept of the fog of war, but I would argue right now we're in the fog of science. In a way, we've gotten away from the scientific rigor. There's been so much pressure to get information out, and as a result, we're being deluged with information. Eventually, this was all sift its way through, but right now, it's really up to us as the scientists and the leaders and the thought leaders in our community, in our society, to do the best efforts we can and try to present the most accurate and detailed information for our society. So thank you very much for your attention.
Thank you, Suresh. That's another amazing talk, and thank you again. And I will leave the questions to the end. And I would like to invite my another good friend, Dr. Ajit Thomas. He's one of the top neurosurgeons in the country, and he's a very unusual neurosurgeon that is very humble and more like a radiologist than a neurosurgeon. Thank you, Ajit.
Thank you, Suresh. It's always good to see you. And thank you for giving me this opportunity. When Dr. Reddy asked me to talk about neurosurgical problems in COVID, I had to confess that we really don't have any neurosurgical issues with COVID, at least from a pathology. So I wanted to spend a little bit of time talking to you about how it has impacted our practice. The only thing that we see that is different is what Dr. Suresh Mukherjee just showed, the embolic infarcts that convert to hemorrhages. So we have seen a few more of those than what we usually see. And unfortunately, a lot of these patients that we have seen have been catastrophic hemorrhages. So Beth Israel has had a very large number of patients in the ICU. Of the 700 or 800 patients we have admitted, I think 200 or so were in the ICU. And many of these patients are paralyzed and nursed prone and ventilated. So what happens is a lot of them do have our own anticoagulant therapy. And in addition, they have high D dimers. And they've gone on to infarct and then hemorrhage. And unfortunately, by the time they are examined, because they're nurse prone, we don't get a neuro exam that frequently. We see these catastrophic hemorrhages, and it's often too late to intervene. Beyond that, we have not had a big change in our neurosurgical practice from a pathology standpoint. The second thing is to do with what Ajay had mentioned, and Lou had also mentioned. Is there an increase in the number of COVID-based large vessel occlusions? The first report of this came from New York. And subsequently, there have been other reports from New York that have contradicted that. And we have actually tried to put together a group from the New England area. And as Ajay demonstrated, we have really not seen an increase in the number of large vessel occlusions. So though there is a pro-coagulant part to COVID, it has not translated it into increased number of large vessel occlusions at least for the brain. What has been most difficult for the neurosurgeons practicing has been the complete loss of control. Neurosurgeons generally like to be in control of things, and now we are confronted by a situation where the hospital administrators, the state, the people who run the state and the federal government has brought in all these regulations as to who we can operate on, when we can operate on. And this has been a fairly big problem for us. So we have been restricted to doing surgeries that are only urgent or emergent. And how do you decide that? We have a committee that goes into it. But I think it also is kind of gray because a lot of the problems we have are not clear-cut. They're not elective or emergent. I want to just give you an example. So if you have a patient with trigeminal neuralgia who has very severe pain, is that an emergent situation? Trigeminal neuralgia is something that drives people to commit suicide. Or we have an aneurysm, which is a centimeter big. Do we treat it emergently or do we delay it for 3 or 4 months? So these are the problems that we confront. And this is more so in spine surgery than in other areas. In spine, what we have found is that degenerative disease is considered an elective procedure. But a lot of degenerative spine disease often has emergent issues. An example would be myelopathy, which is progressive, or a metastatic disease with spinal cord compression, or a foot drop, which is acute. So we've struggled sometimes to actually figure out what is urgent and emergent. The other problem we've had is the use of intubation. Very often after intubation, there is aerosolization of the COVID virus. And we have to wait for 30 minutes. And we have to often find a negative pressure room to do the procedures that we want to do. And that often results in significant delay, Ajay showed from Clemens Shermer's data. So in a nutshell, I think what we are struggling with is the difficulty in doing the procedures that we want to do. And I think over the last couple of weeks, this has increasingly improved. And for the first time, we were able to do 70% of the procedures that we wanted to do. So that's a nutshell of what neurosurgery is going through.
Thank you, Ajit. Thank you for joining and thank you for the wonderful talk. Next, I would like to invite Dr. Anil Yellapragada. He will be talking, and after that, he will take over as moderating the QA session. Anil.
Thanks, Dr. Reddy. Appreciate it. And thank you, Dr. Kaplan, and all the other wonderful speakers for covering so much detail. I'm just going to speak for about 5 to 7 minutes, kind of freestyle, because a lot of this stuff we already discussed. But I'll say, as a stroke neurologist, working in the buckle of the stroke belt in South Carolina, we have a unique perspective with one of the biggest stroke centers and busiest stroke centers in the country up until recently. And what we saw is what Dr. Kaplan had actually beautifully and eloquently stated is that there's a rapid reduction in the number of people showing up to get care. That's one of the observations that we've had here, but not only here, but around the country. This has been commonly what is being seen. Just today on a podcast, Robert Harrington, who is the president of the American Heart Association, was saying up to 30 to 50% reduction in patients who are showing up to get care for acute stroke, and not only acute stroke, but even cardiac disease and other acute illnesses that typically they rush to the hospital for. If they're able to tolerate it, they're just staying at home. And there's a lot of questions as to why this is. There could be this counter public health campaign, one telling people to stay home, and then one that has been going on for years where we tell people, time is brain, and to come in to get treated as quickly as possible. So there's this massive counter, almost like a counteraction that has suppressed a long-going public health campaign of time is brain or call 911, know the risk factors, know the symptoms, signs and symptoms. And so we witnessed that as well, just like it was shown in, I think, the Lehigh slides and the Beth Israel slides, that, we saw a rapid reduction in the number of patients showing up. And part of that could also be not just the public health campaign, but characteristically, when people aren't social distanced, we start to see other people identify that someone's having a stroke and then incite them or activate 911 by themselves. And I'll just give you an anecdotal, observation I made during Memorial Day here in South Carolina. They'd opened up the beaches, and, all of a sudden I was on call that day, and we were just getting slammed with strokes because people are around each other again. So they're noticing stroke symptoms in someone else who otherwise may not recognize it in themselves, or may not be able to activate 911, or may convince themselves that, hey, I don't want to do it. But then the wife says, no, you're going to call, we're going to take you to the ER. So that could certainly be a possibility as well as an explanation. But one of the big things about stroke is stroke systems of care. And stroke systems of care is very much at the base of it is activating 911, activating that systematic tree of, alerting the first responder and getting the hospital with pre-hospital activation, the team's ready, and so that the imaging capabilities can be done quickly. And so when you start messing up with that paradigm, as far as, how are we going to do this most efficiently in the setting of a pandemic? How are we going to manage an epidemic in the setting of a pandemic, the epidemic being stroke, which is a very, very common disease and most, very deadly, high morbidity, high mortality index globally. And then you have to manage with how EMS is going to be precautionary to COVID. Our patients going to be comfortable coming to the hospital. So there was this rapid push to kind of facilitate safety precautions for both EMS and hospitals, reassurance for patients to come, please come seek help. So there's this additional public health campaign that's ongoing now that's kind of trying to push people back into the hospital and make sure that hospitals are completely safe for patients, which they are, especially in the comprehensive stroke centers around the country have taken these precautions. And those are some of the underlying baseline issues of getting the patient into the hospital. As far as patterns of stroke that I saw, one of the first patients I saw during the COVID, who was a COVID positive patient, actually turned out to be what we diagnosed eventually as, destabilized intracranial athero. Patient who had, severe intracranial athero and then had the COVID infection, was getting worse and worse. And then during their hospital stay, ended up developing these multiple strokes and the distribution of these plaques. So we thought it was destabilization, something Dr. Kaplan was alluding to with patients with ulcerative colitis or Crohn's disease, or sometimes we see those with patients who develop UTIs or other infections that can destabilize what is already an inflammatory immunological disorder, atherosclerosis. So these acute phase reactants can destabilize those plaques and cause these, thrombus or thromboemboli, artery embolus, in the distribution of the vascular territory. So that's one mechanism that we saw. One of the other ones that's really hot, that's been really mentioned around, there's a number of mechanisms, but I would like to back up just COVID in general, is, the initial reports out of COVID from China and Wuhan, China and other parts of China were these things called COVID toes. And what they were witnessing was these microthrombi, or these, purple dots in the fingertips and the toes. And this was initially seen as a sign of some kind of a thromboembolic microangiopathic thrombi or thromboembolus. And so then they started to see this kind of thrombotic disorders in the kidneys, especially in patients who were being treated eventually for dialysis. They were starting to see that the blood was thicker, or they were starting to notice the different patterns of multi-organ thrombotic disease. So a lot of the patients, they were suspecting, well, is this actually a pulmonary embolus? It was actually not pulmonary embolus, it was pulmonary thrombosis. And they saw that on autopsy, that it was actually, they suspected that maybe these patients were just having these in situ pulmonary events. Even though most of the diseases that we see in the vascular system, we attribute to, or we think about strokes and heart disease, but the vasculature that's affected is most commonly the veins. But from a cardiovascular standpoint, I think Dr. Kaplan and someone else had talked about the cardiac involvement with the myositis or the myopathy that can develop, but also just the systemic involvement within these vessels, within the endothelium, which is what we're calling as, now it's not just a neurotropic, but it's not just a respiratory disease, it's vascular tropic, and it's an endotheliopathy. And we've seen endotheliopathy with other diseases beyond COVID. I mean, it's been seen in the initial COVID, the initial SARS viruses, but also things like with DIC, you can see this microangiopathic disease. You can see it with sickle cell. You can see it with other diseases. But this is very unique. And one of those unique features was presented a couple of times today, but about looking at different levels of that differentiate it from DIC, specifically the elevated fibrinogen, which was pointed out. But one of the other things that's very significant is the presence of factor VIII, which is basically secured under the endothelium. So people with cirrhosis, you may not affect their factor VIII because it's in the endothelium, but in this particular disease, they suspect that the viral particles are actually binding ACE2 receptors on the surface of this endothelium, which is allowing for entry of the entry or damage to these endothelial vessels. And this is what's thought to happen at the end state of the vasculature, end state of the alveoli, actually, what's initially presenting with the pulmonary systemic spread. But as it goes into these different organs, i.e. the brain itself, you can start to see this endothelial damage sometimes and present with different patterns of stroke, whether it's a small lacunar stroke or even some of those reported large vessel occlusions. And one of the theories is that the varied presentations as far as information that's coming in is that we're getting presentations rapidly, just like one of the speakers was just talking about, from all over the world every day. There's an influx of information, but there's influx of information in different populations. So populations who have underlying cardiovascular disease risk factors at high prevalence will present differently than another population maybe that has a different expression of the ACE2 receptor in different parts of their body. There could be a racial difference. There could be a cultural difference, a geographic difference. And so we're seeing all kinds of reports, and it's not that they're contradictory. It may mean that the disease is variable. And so we're still learning how this virus acts, but we're learning how it acts in different places, different times, and maybe there's different viruses and strains being involved with different activity levels. And when you combine that with the cytokine storm and the inflammation, it explains why we see these vascular events typically are in the end stage or are more severe stage of the illness, not in the early stages. It's kind of like a delayed presentation. And what they showed in China actually was an initial report that 40% to 40% of the patients who actually died of cardiovascular disease complications, of the disease itself that causes them to have an end state MI or stroke or whatever it is. And so the reason that might also be is because of the higher prevalence in that particular patient population of cardiovascular disease risk factors or history that then kind of tip the balance. So that's something to look at too, is the racial disparities, racial presentations as well. So we have a number of mechanisms, a number of presentations, and the management will vary. And there's a lot of studies going on. I mean, there's even a trial going on with eculizumab to look at the effect of complement cascade because there's such a complex hypercoagulable involvement. So some people want to try dipyridamole or aspirin, starting aspirin early, looking at D-dimers and how to go forward. So I'm going to go ahead and stop here because I can ramble on. Let's go to the questions.
So, thank you. My name is Sumul Rawal. I'm a neurologist and a neuro-oncologist practicing in New Jersey. Being an epicenter of COVID in New York and New Jersey, I felt a bit surprised to learn so much new information, as we learned that there are the less number of COVID patients, less number of stroke patients, COVID related, where we saw plenty here in New Jersey. So I think we have, as many of us mentioned, informations are so much and so fragmented, it is unclear that how much is really documented information versus how much is information that people are saying it based on their observation. We have so many good, interesting questions, and I'm going to start with one question that I wanted to ask for all of the speakers. So the question is, most hospitals are under-reporting COVID, and what can we do to make this as properly reported so that we can either predict the true incident of patients coming into the hospital with COVID and associated other diseases, including strokes?
I can jump in on that. I don't know if hospitals are necessarily underreporting it. You know, one of my roles is at a couple of national organizations is that the definition of a COVID positive patient varies amongst hospitals and it varies amongst state health agencies. So for instance, in the state of Indiana, there are COVID positive, quote unquote, they're being reported to the state as COVID positive if they had signs and symptoms of COVID, even though the PCR tests were never performed. So at some point, and you probably heard this in the labor press, there was a sense that there was an over-reporting of COVID because COVID patients were being reported that were never truly positive. Now, the flip side of that is that when you are in places like New Jersey or New York, et cetera, that have a large social disparities based on economics, the concept of social disparities of health, there are probably patients that have died that have never made it to the hospital of COVID that were never really tested. So I would think it would eventually balance itself out. But to answer that question specifically, I think moving forward, we need to standardize our definition of what is a COVID positive patient. And then we can have real data to answer many of the thoughtful questions that are coming up on the chat box.
And I think that's a very important information you mentioned, because as we know, we don't have universal positive and versus case symptoms at present time. So it is kind of important information that we need to put together.
Maybe I can, yes, Ajay, maybe I can echo what Suresh was saying. At Lay, Beth Israel, and Ajit knows that we are tracking everyday patient population within the system that either are on ventilators, are in the ICU without ventilators, and patients who are in the regular unit dedicated to COVID, and those who are discharged, those who die, or those who suffer significant morbidity. This is on daily basis tracked very well. And I think this applies to most, if not all, hospitals in the Massachusetts area. This is mandated by the governor and it's tracked very carefully. I can't speak for other states, but I do know from my colleagues in Florida, for example, that due to the economical impact of these kind of informations, that it is being suppressed. It is underreported. As you know, from Florida, there was this lady from the healthcare system who was dismissed from her position. So I do agree with you that it may be regional different, and for many reasons, economical reasons, fear, people are afraid of fear mongering and that they may lose patient population for other treatments. But I have to say, and Ajit, you may want to chime in Massachusetts, it is very carefully and well monitored.
I have to agree. I think Massachusetts has been very progressive, and you know, Charlie Baker, the governor, has been very involved with our hospitals, and it's a very different environment, say, from Florida or Texas. Yeah, I think one thing we don't clearly know is the outpatient COVID. So if you come in and have a COVID test and you go home, I'm not sure that's being tracked.
Thank you.
I think just to chime in on that as well, I think the American Heart Association has put a few $1 million into building a national registry to track these patients and follow them, so we can retrospectively even analyze some of the qualities and findings of the stroke patients with COVID.
May I ask a question, since you represent the Indian Association, the American Association of Indian Physicians? Why is it that in India, where we are approximately having 400,000 infected patients, the mortality or the fatality is only 3%? Do we have any explanation for that? And other countries are seeing mostly around 5 to 6%.
I can jump in on that. The latest data that I've seen, I think it's right now we're dealing with an epidemiological phenomena. The latest data that I've seen is that the mortality rate in the US now is less than 1%. And that is, I think, initially the reports were 4%, 2 to 4%, and that was based on, I think it was pre-selection bias, which in the sense that because there weren't enough tests in the United States, the people that were getting tested were ICU patients. So the pre-test probability was very, very high. Now, there was a study that was just completed in, I think in Indiana and the California study said about 3% of the population is COVID positive. And these are normal outpatients. So the data that initially came out, on CNN, where they would have the ticker where they would say like, these are the number of deaths and these are the number of the positives, and everybody would do a back of the envelope calculation and say, well, positives, deaths versus positives, and you do the division and it comes out to 3%. Now that there's more testing of asymptomatic patients, I think the overall mortality rate, if you will, which is the true death rate versus all positive patients in our society in the US, is probably less than 1%. So I think India probably has a little higher, the ability, I think their testing capabilities are a little bit more, but they're probably in the peak. And with time, as things subside, my sense is, and this is purely hypothetical, but I think this is where the world data is going, is that the overall mortality will be 0.5%, but it will be higher in patients that are older, like myself, and also that have pre-existing, those of us that trained in the last century, and those of us that have pre-existing conditions, I think they'll have a higher mortality.
The interesting thing about the mortality figures, at least in the United States, is that the overall mortality is down. If you look at the number of deaths per month, though the COVID-related deaths are higher, the actual number of deaths are lower. And that means that it's probably because people are not traveling, there are less accidents, people are not doing dangerous things. In other words, modern life is inherently dangerous.
Because I think that what Suresh mentioned, I think that's interesting. And that goes back to this subpopulation. So we put together the data in Northeast. It was spearheaded by Adam Dimitri from Toronto. It's a small population of roughly 70 patients. And what we found is that patients with stroke and COVID positive, the mortality in the African American community was 50% higher than in all other races. I'm not talking only about Caucasian, but all other races. And I was wondering whether in the Indian population it may be lower because the Indian society is younger as compared, for example, to the Italian society, where you have older patients, and the average was, I think, one of the publications, 70-some plus year. So that may factor into that the Indian community is just much younger than other societies in the Western countries.
Thank you. This was very...
I think Dr. Kaplan's trying to speak. Somebody. Dr. Kaplan's trying to speak. Vijaya, can you help Dr. Kaplan? Hi, Vijaya, can you please turn on? Okay.
Yeah. Dr. Kaplan's speaker is on mute.
Yep. Okay. Unmute him. Thank you.
Yeah.
Okay. Yeah, just one comment. At the beginning, when it first came out, there were a lot of healthcare workers that were affected. And so actually the number of people in the hospital was less. One of the things, and there were less there to take care of people. One of the things that I think has happened is there's been a striking decrease in the number of doctors and other healthcare workers that have gotten it. And there are more people there working, and they've learned a lot of how to deal with it. So I think there is a learning curve in how to deal with it that has really helped and has reduced some of the mortality and has had more people available to take care of, especially residents and other people in that.
That's very interesting, Lou, because in Wuhan, in Hubei, originally I think like 600 healthcare workers died.
Yeah.
But then once that initial phase was over, and they gotten all these people from Tianjin and all these other places, there was not a single death among the healthcare workers. And I think part of it is, like you said, we had learned and there was more availability of PPE.
And also, this is Suresh. Talking about the India, actually the next lecture coming up is epidemiology comparing India to US. The average age for Indian population is around 26 years. So that's very young population. And the older population is less. And also, I think there is a very underreporting of deaths, because death from COVID has become a big taboo, because nobody wants to know that's because the family is boycotting them, the villagers are boycotting them. It has become a big taboo. So that's why I don't know if the deaths are really fully reported as COVID. It could be some underreporting there.
Yeah, I think that's so much true. So there are so many questions we have. I'm going to ask one more question from the audience. So there has been significant discussion about COVID incidents among minority communities. Have you seen any similar incidents in stroke with the similar pattern? And this is open for Dr. Kaplan.
I don't know the answer to that. You know, the difficulty is that a lot of the hospitals have a varied percentage of African Americans and Asians and whites. So you'd have to factor in, you know, what your hospital has. So I don't know that there is good data about that, at least in our hospitals.
Thank
Does
you.
anybody know?
I don't know if off the top of my head. I know there was something I read it's been a while now, about a month and a half ago, from Ireland, and they were reporting, because they had it was in a city in Ireland that had a diverse population, and they were trying to that wasn't a very high end, but they were trying to stratify on how different patients of different races did in that hospital with COVID, because they had a COVID outbreak there. But they were trying to allude that there's some kind of connection between this racial difference. But just a side note, you know, I speak at a lot of churches in South Carolina, a lot of African American churches, and one of the things that I noticed was that, you know, there's such a high prevalence of cardiovascular disease risk factors. So there is a concern that as a population, are they more susceptible? So that would be my observation, that, you know, there is a worry that maybe they're more at risk for having cardiovascular disease or stroke risk factors. And as they shit out of China, these are the patients who did the worst as the illness became more and more severe, the ones who had underlying diseases.
I think one thing that I can say is that my cousin is the PI of the Masala trial, which is an incredibly well-funded, Alka Kanea, she's the PI of the Masala trial. And her study has clearly demonstrated that Asians have a higher cardiovascular risk factor. And I think they actually changed the cholesterol levels or a little bit lower to account for that. So if indeed this is felt to be a pre-existing condition, higher risk of cardiovascular disease, then the natural linkage is going to be because Southeast Asians, and someone put in the chat box a very thoughtful comment about, when I grew up, we didn't call people from China and Hong Kong and Singapore Asians. Asians were Indians. So I have to make sure that now we're Southeast Asians as opposed to Asians. So again, the definitions vary, but I'm specifically referring to people of Indian heritage, and which is a mixture of the Aryans and also the Dravidians. So that group specifically, because the cardiovascular risk factors are higher, then therefore theoretically we would be at higher risk for potential complications from COVID.
Thank you. Thank you. So one or other questions for Dr. Mukherjee. Did you come across any spine findings, spinal cord findings? We talked a lot about the brain findings on neuroimaging. Have you come across with the spinal cord findings, especially or any root enhancements in a GBS patient?
Yeah, that was a great question. I saw that. I forget who asked that. It was a great question. I personally have not, given the fact that ADEM, if you will, that we're seeing in the brain is an immunologic response and maybe a big robust response from the cytokine storm that can spread into the brain. I would assume that what we would see mostly in the spine would be findings that would be typically seen in transverse myelitis, as opposed to more of a CIDP, a chronic inflammatory disease involving the nerve roots, which is more prolonged in time. So I personally haven't seen them, but if I was specifically looking for spine findings, I would think they would have more of a pattern of transverse myelitis as opposed to Guillain-Barré type nerve root enhancement.
The question for Dr. Thomas here. Do you think there is overlap between amyloid angiopathy versus the COVID microhemorrhages, given that many patients are older? I think you had shown an image that might have looked like amyloid, possibly.
I don't think I showed the image, but the hemorrhages that we have seen are not amyloid kind of hemorrhages. Most of them have been, like Dr. Mukherjee showed, embolic events, infarcts, which then convert to a hemorrhagic lesion because the patients have been on anticoagulant therapy.
Yeah, the only thing I'll add to that is someone asked on the chat, is another great question. Again, back in the dark ages when I trained, I remember when we first started doing gradient echo imaging, and what we were specifically looking for were these small microhemorrhages. And we started doing it and we saw them and we didn't know what to do. Does that mean we had people walking around with brain bleeds? And eventually we kind of figured out that as you get older, amyloid angiopathy and the amyloid changes are part of a degenerative process. Now, granted, they have a different rate of progression that's individual and amongst all of us. So when we talk about associated diseases, if you did someone that's 60, 70, 80 years old, and you saw a bunch of punctate lesions in a patient with COVID, I would probably argue that's due to amyloid angiopathy. But when you look at someone that's young, like Suresh is, or Dr. Kaplan is, robust in their 30s and 40s, and you see, then you start seeing these punctate areas in patients with COVID, then I think I can make the transition that this may be due to some type of vasculitis and microhemorrhages due to COVID. So I think it depends on where we set our rheostat.
Very interesting, thank you. So this question that they ask us almost every day, and this is from my stroke neurology colleagues, Dr. Kaplan and Anil. Any thoughts on thrombotic risk, DVT post-COVID recovery? Should they be on anticoagulated?
I don't know the answer to that, but
Vijaya, can you put the speaker on again?
Sorry.
Thanks.
What they're seeing, what they're doing because of the pulmonary embolism, they're putting everyone on relatively low dose of heparin, and then the issue is some of them they're putting on higher dose, and I think it's difficult to know now what to use, whether to use the D-dimer, whether to use some of the blood studies, whether to use clinical judgment or not. But all these patients, I think, are on at least low dose of anticoagulants, usually heparin. I don't know that they've tried very much in the way of the newer anticoagulants.
Lou, there's an interesting finding. So at our place, when we had to place the dialysis catheter central lines and A lines, it was interesting that how frequently, despite anticoagulation, we had to change the lines. I had never done that, especially in the dialysis patients. They would clot within few days, so we were constantly looking for accesses. So there must be more than only, the simple upregulation of the clotting cascade, intrinsic or extra.
Yeah, some of that is a high fibrinogen.
Yeah. Yeah, the D-dimers, like you said, are super high.
Yeah, so to answer Dr. Raval's question, I agree with Dr. Kaplan. I think there's still that we don't understand, and I guess it's on a case-by-case basis, and and also measuring the risk of hemorrhagic conversion if these patients do leave out with a stroke, and doing it in a timely fashion. But I don't think that it needs to be a standard standard method, because it just varies on a case-to-case basis right now. We're still trying to understand how to do it most safely.
Thank you. So the other question that came up on our chat right now is, like all the procedure, most of the hospitals have a policy that they test for the COVID 2 to 3 days before any scheduled procedure. Is it all your institutions, is it standard that all the patients come into the hospital with stroke-like symptoms be treated differently than a normal situation, or tested for all of them for COVID as well?
So for us, for a neurosurgery procedure, we test all of them at least within 48 hours before the procedure. Patient who comes in with a stroke-like symptom, we assume if they go on to a thrombectomy, we assume that they are COVID positive, and we use an N95 mask and PPE.
I think we are, of course, almost the same system, but what Ajit is saying applies for procedures as well as OR. The differences they are making, and I didn't spend too much time on the workflow chart, is that we classify patients into previously COVID positive, symptomatic, and then now asymptomatic, and they need to be retested. Then there's a group of patients that's COVID positive and is asymptomatic, and the last group is COVID negative and asymptomatic. So we classify these patient population, and the COVID test has to be taken within 72 hours. So any test that's older than 72 hours at BILH system is not valid. So the patient has to undergo, whether it's for urgent, semi-urgent, or elective cases, they need to be retested. That doesn't apply for urgent care, of course, because most of the stroke patients, we don't have the time to do that. So what we are doing now is, in these patients, if there's the slightest chance they may be symptomatic, if we have the information from the family members, or they are not capable of communication, we proceed and do all the procedures under general anesthesia. The recovery is then generally done in a special area or in the intensive care unit, just to reduce the particles and the transmission in the room. Now, there is, of course, constraints to the OR facility, and Ajit knows that after the deep cleaning, the room cannot be utilized for 20 minutes.
Dr. Waklu, I have a follow-up question for you, actually. So have you seen in your experience recently patients who required thrombectomy with a COVID-19 infection?
Yes, but I have to say we do about from January to May, we are overseeing like 40 patients now, a little bit more, and there was only one patient who was COVID positive. So I do agree with Lou's initial comment that unlike in New York City, we are not seeing that the numbers of the patients with COVID positive.
Same with us, yeah.
Same, yeah. It may be, I don't know, we don't see that in Massachusetts.
Thank you.
I think there's time for one more question.
So
I'd like to ask Dr. Kaplan a question, unless you have one, Dr. Raval.
no, you go ahead.
So, Dr. Kaplan, maybe you could just summarize your thoughts. I was just curious to see what you thought about this. Is a unique situation, and you're kind of, the father, one of the fathers of stroke neurology, and this is a new presentation of a virus presenting in such a way with so many mechanisms and presentations. Any kind of final thoughts on COVID and stroke?
Well, with what Suresh had said, I think one of the things that's been impressive to me is actually how much research is being done. And if you look at pandemics in the past or war, even though they've been tragic, they've been an opportunity for people in medicine to learn something. Here, learning something about coagulation that we clearly don't understand, it's not very simple. And then learning something about the endothelium, learning something a little bit about the target of where it is. And I think we're all learning, and it's so quick and some of the information, you know, differs. It's going to take some time to sort it out, but I think we're all acquiring data. We're talking with each other. We're collecting cases. We're collecting information. And I think with time, it'll sort out. It's just too quick to come to any definitive kinds of things. So we have to keep an open mind about our treatment. And I think also, as was highlighted, it's probably very individualistic. It depends a lot on genetics. It depends a lot also on comorbid diseases. They may be very different in different populations. So I think we're all learning and we're all talking together. And I think that's one of the nice things about this meeting. I certainly learned a lot.
Thank you so much, Dr. Kaplan. And it's been an honor to have you all giving your experience and knowledge on this very unusually unique situation. I think we have so many questions, but because of the interest of time, I want to have our BOD chair, Dr. Seema Arora, say the few words.
Good evening, everyone. I'm Dr. Seema Arora, Chair, Board of Trustees of API. So it's amazing, rather frightening to see how COVID-19 can involve all the systems of our body. And today it's been very educative to learn about how it can involve one of the very important systems of our body, the brain, and the nervous system. So I would like to thank all the esteemed speakers, many of whom are from my hometown, Massachusetts. So I'm very excited to see that. So thank you, Dr. Kaplan, Dr. Vakalu, Dr. Mukherjee, Dr. Yalapragada. I always have difficulty pronouncing that, sorry. So, and also thanks to our moderators, President Dr. Reddy and Dr. Raval. And thank you to all the audience for attending. I would like to request everyone to stay in this room only for our next session, which is going to start soon. And it's, again, a very important educative session regarding COVID epidemiology updates. Thank you, everyone, and we'll see you soon.
Thank you, Ajit Thomas, and thank you for joining, and thank you, Dr. Kaplan, Dr. Vakalu, Suresh Mukherjee. It's an honor, and it's amazing to see all my old friends and mentors here. Thank you.
Thanks.
Thank you.
Thank you. Good night.
Thank you.